Hey guys, we are on chapter 14 and we are going to talk about personality disorders today. Personality disorders is a fun topic. I always found it fun to kind of think about, friends, roommates, family members that maybe you've always just struggled to get along with. And see if they have any of these particular traits. Now, again, don't actually go around diagnosing people. That's not necessarily the thing to do. However, this is kind of fun. Okay, so personality disorders. First, it's important to talk about the difference between a personality trait and a personality disorder. Okay, a trait is an enduring pattern of perceiving, relating to, and thinking about the environment and others. Okay? Sometimes when we talk about traits, we talk about trait versus state. And the state is sort of how I am right now. And a trait is this sort of pervasive pattern of the way you think, the way you feel, the way you relate to others. Okay? Now, a personality disorder is this ingrained patterns of relating to other people, to situations, and to events, excuse me, with a rigid and maladaptive, and that's an important word there, maladaptive pattern of inner experience and behavior. Okay, that's a lot of words there, right? We want this to date back to adolescence or early adulthood. Okay, so one thing is we don't diagnose a personality disorder in a child. The person has to be at least 18 years old or older. But when we diagnose the personality disorder, we do say, gosh, this person has been like this. This is the way this person has kind of, quote, always been, right? Sometimes we say, man, they came out this way. Sometimes it develops, but really, really you see it big time come out in adolescence, right? That's when we sort of become who we are, if you will. During adolescence, you really see these personality disordered traits come out. But we're not going to really diagnose it until early adulthood or later. Now, the nature of personality disorders is that the behavior patterns have to manifest themselves in at least two of these areas. Okay, so at least two of these. Cognition, so the way you think. Affectivity. Remember, affect is sort of the way that we feel and the way that we show expression. Interpersonal functioning, how you relate with others. And impulse control. You should know what that means. Now, within the DSM-5, we have 10 different personality disorder diagnoses. And they put them into these three clusters. Okay, cluster A is the odd and eccentric behaviors. Cluster B is these dramatic and emotional behaviors. And cluster C are these anxious and fearful behaviors. Okay, and again, we have several diagnoses under each cluster. For nerdy psychology people like me and my husband, or other friends, we will sometimes meet someone who is a bit dramatic and emotional and, well, okay, by a bit, I mean a lot. And we can simply kind of look at each other and say, like, cluster B. That's a lot, right? Okay, so you ready? Let's start. Let's do odd and eccentric behavior personality disorders, all right? Now, with cluster A, in the DSM-5, they include these disorders characterized by, as we mentioned before, eccentric behavior. So in other words, right, these individuals with the disorder show characteristics that might lead others to view them as a bit odd, right? Or that person is, right? Like you meet someone and you just think just something about them is a little odd. They're a little peculiar. They're a bit maybe eccentric, and you kind of can't put your finger on it. And that's something actually I should say about personality disorders is really the way we start to think about them is when you're talking to somebody and you just think, I'm not that comfortable in this situation. Like I there's something about this person that makes me feel uncomfortable, or like I kind of don't want to be in this conversation anymore. Okay. And that's why people with personality disorders often end up pushing people away, whether or not they want to push them away, whether or not they mean to, they kind of do. Okay. So these people are those people that you're with that you're like, I don't know what that is, but it seems a bit odd. Okay. The first one is paranoid personality disorder. This is a personality disorder whose outstanding feature is that the individual is real suspicious of others. Like real suspicious of others. They're kind of always on guard against potential danger or harm. Okay? Now this is not a person with schizophrenia. This is not a person who is feeling this way because of a PTSD situation, right? This is just who they are. They are just generally a paranoid person. They really struggle to trust other people. So you can imagine how that works in relationships. They tend to project blame onto other people. And they tend to refuse to seek professional help because they really believe what they believe, right? So they really feel like, yeah, people just are out to get you. Like everybody is out to get me. It's just how it is. Maybe you think that somebody has put cameras in your house and like you don't actually think it, but you kind of think it's possible, right? And again, it's not in a schizophrenia type of way, but it is in just a paranoid, generally paranoid way. This is a miserable way to live, but people do it and they don't seem to want to seek professional help because those people may also just be trying to mess with them. Okay, this next one is schizoid. Okay, and there are two different personality disorders that look similar. There's schizoid and there's schizotypal. So you'll really want to know the difference between these, right? So schizoid is a personality disorder primarily characterized by an indifference to social, sexual relationships, as well as a limited range of emotional experience, a limited range of emotional expression. Okay, this is the person who like lives in their mom's basement and is totally good with it. Okay, they're not trying to be creepy. They don't understand why people would want to hang out with others. They don't understand why you would want to like fall in love or get married. They just like don't get it. They prefer to be alone. They have no desire to love or be loved. They're insensitive to other people, which causes issues. They're perceived by others as cold, as reserved, as withdrawn, as seclusive. That should say. Okay. So if you can kind of think about that, right? So now this person, again, is not trying to be mean to others. So this is not like an antisocial kind of thing. This is just someone who really just kind of like doesn't give a whatever about anything else or anybody else. They just like don't care. They don't care to be mean. They don't care to be nice. They just like, they're good. If they can have a job or they can sit at home by themselves, just get stuff done by themselves, ideal. Okay, and they think other people are weird for having other ideas about this. These people tend to not be interested in sex. Like, just not. Again, nothing creepy, just not. They're just not that interested. Okay, now schizotypal, on the other hand, is a personality disorder that does look like schizophrenia. So if you think about typal type, it's like schizophrenia type personality disorder. It involves odd beliefs, behaviors, appearance, and interpersonal style. People with this disorder may have bizarre ideas or preoccupations with things. They may have some magical thinkings. They may believe in like psychic phenomenon. With these individuals, you kind of see social isolation, eccentricity. They often communicate in kind of weird ways that they think are okay. They tend to have poor social adaptation. It seems to be within some sort of schizophrenic-like spectrum, but these individuals don't necessarily have like the hallucinations and the delusions. And also with this, you do see it kind of come on in adolescence and be persistent versus like schizophrenia where you see these like this psychotic break that happens. Okay, I feel like I said that's super dramatic. All right. So treatment for schizotypal. Really, it's going to look a lot like interventions used for treating schizophrenia. Okay, we're going to see these medications that act on dopamine are most effective. They really can seem to alleviate these cognitive deficits in memory and in executive functioning. Okay. All right, so those are our odd and eccentric ones. We are now moving on to the dramatic, the emotional, and the erratic. So say it like that because these are these ones that you hear more about. Alrighty? First, we're going to start with antisocial personality disorder. And I put these words in because sometimes people will use these words, like psychopath or sociopath. That's what we're talking about when we use the term antisocial personality disorder. A person with antisocial personality disorder has a lack of regard for morals, for the way society thinks things should be, for the law. They have issues with impulse control. They tend to live risky lifestyles. They just generally have this lack of regard for the rights of others. They just don't give a thing, but in a different way, right? So I mentioned with schizoid, they just don't care. Antisocial, this is messed up, right? Somebody with antisocial personality disorder often does some time in prison or doesn't because they've been so manipulative that they manage to not get in trouble, right? So that is where somebody says something to them and they're like, no, let me tell you why I'm just going to continue to do this behavior that I'm doing that you really don't like because I want to. And that's what I'm going to do, right? This may be the person that keeps heads in their basement, or it just may be somebody who, really likes to steal. Well, that may be a little bit too not antisocial personality disorder enough. So if you remember back, we talked about oppositional defiant disorder, and we talked about conduct disorder. Antisocial personality disorder is the adult version of those things, right? So sometimes people with oppositional defiant disorder end up having a conduct disorder diagnosis. A lot of the kids with conduct disorder diagnoses end up with an antisocial personality diagnosis later. Okay. So psychopathy. Psychopathy is a cluster of traits that seem to form the core of antisocial personality. Okay. A lack of remorse, a lack of shame for harmful acts that are committed to others. No guilt. That's scary. Poor judgment and failure to learn from experience. Yeah, they got arrested for that, but they're gonna do it again. Extreme egocentricity. Okay, egocentricity, you may want to look that up if you're not familiar with the word. Egocentric are things that you do that make you feel good, and in this case, with a lack of regard for what others feel. We seem to have this incapacity for love. They may tell somebody else that they love them, but they have no idea what that means. A lack of emotional responsiveness to others. So no empathy, right? Somebody else is crying and they're like, stop. Impulsivity. This one scares me also. An absence of nervousness, right? So this individual can just lie straight to your face with no inkling that they may be lying. No nervousness. A combination of unreliability, untruthfulness, and insincerity. When I talk about this with clients who maybe know somebody with this issue, they usually say, it's like they're missing a chip, right? It's like they're just missing that little human component that most people have. So with antisocial personality disorder, the diagnostic criteria require that an individual show a pervasive pattern of 3 out of the 7 of these. Failure to conform to social norms, deceitfulness, impulsivity, aggressiveness, disregard for the safety of self or others, irresponsibility, lack of remorse. So, antisocial personality disorder seems to emerge in childhood, as I mentioned, both in terms of the development of psychopathic traits and the rates of breaking the law. Over the course of their adult years, people seem to become less likely to commit criminal acts. Maybe that's because they become more manipulative. Maybe they kind of have figured out how to work the system, things like that. There's something called the maturation hypothesis. Okay, and the maturation hypothesis suggests that older individuals are just better able to manage these high risk tendencies. Okay, just better able to manage. As you can imagine, people with antisocial personality disorder do not often come to therapy. Sometimes they are mandated to do therapy, and I mean, there's not a whole lot you can do about this, right? However, with personality disorders like this, we often try to teach them how to live in society. We don't tell them they're wrong. We don't tell them that they have to change their feelings or emotions. We basically try to say, let's talk about how not to get arrested. Let's talk about what things you should not be doing in order to not get arrested. Okay? We have these different perspectives on antisocial personality disorder. Oh, I should mention this also. Some people try to teach empathy. That can be a really difficult thing to do, but some people think that if you can kind of teach them to understand how other people feel, that may help. However, the idea behind a personality disorder is that they just don't get that. Okay, so biological perspectives, maybe genetic causes, some different brain abnormalities that we tend to see in individuals with this disorder. These are, correlational. So, some things I was talking about here, but current therapy effectiveness studies unfortunately continue to support the difficulty of working with this population. Problems. They just really don't care to change. Tendency toward deception and manipulation in the therapy setting. And a lack of deep or lasting emotion. Okay. It's difficult to define reasonable goals in therapy. And there's really no one accepted method of effective treatment. Okay. Next, we're going to talk about borderline personality disorder. Okay. So borderline personality disorder, if you're interested in a movie, the movie Fatal Attraction is sort of our classic borderline personality disorder movie. And that, it's a little bit on the old side at this point, but it's sort of just your classic BPD movie there. There's lots and lots of things on borderline personality disorder. This is what some people confuse with bipolar disorder. So I'll have people come in and say, well, I've been told I have bipolar disorder because I'm happy and then I'm sad and then I'm happy and then I'm angry and I'm yelling and then I'm happy or I'm whatever. As you guys know, that's not bipolar disorder. Bipolar disorder would be long phases of mania or long phases of depression, right? Or hypomania. This intense fluctuating mood is borderline personality disorder. If you are in a relationship with somebody or a family member is this way or a friend is this way, this is a very difficult person to be around some of the time. So, okay, we'll go through this and then I'll keep talking about it. We have this pervasive pattern of poor impulse control, instability in mood, instability in interpersonal relationships, and instability of self-image. Okay? The central feature is instability. The way that people with borderline personality disorder relate to others is called splitting. We have this all good versus all bad dichotomy, okay? And we call these dialects. That word's not on here, but the word dialects, and the therapy that's often used is called dialectical behavior therapy. And the idea is that you have two sides, all good and all bad. And there's no gray area. And this is where you end up with this parasuicide. So a lot of times people with borderline personality disorder are cutters, and they cut, and they have, but they cut sometimes because they really are emotionally hurting. But however, actually a lot of the times they cut just to get attention. And so this is different. Some people cut because they emotionally are struggling. Other people cut because they want attention and they want to be like, I tried to cut myself. Give me attention. Love me. Focus on me. You're not paying attention to me? Oh, you think you're going to break up with me? I'm going to show you that I'm going to try to kill myself. Right? They will usually threaten these things. And they kind of almost hold people emotionally hostage because they will say, like, if you try to leave me, I will kill myself. Okay, this is this person who they come into a therapy session and they sit with the therapist and they say, oh my gosh, you're the best therapist that I've ever had and you're the only one that's ever going to make any differences and you're the most amazing thing in the whole world, blah, blah, blah. And then, a few sessions later, the therapist says, who knows what, something benign. And the person is like, you are the worst person in the whole world. I can't believe you said that to me. No one has ever hurt me more than you have hurt me. You are a terrible, terrible, horrible person, a terrible, terrible, horrible therapist, and I hate you. Okay, so this is also why it's difficult to be in a relationship with this person or in a friendship, because this person, again, is some days you're their best friend and the most amazing person they've ever met, especially when they first meet you. And then who knows, randomly, you are the worst person in the whole world. Okay. That makes it difficult, right? These are these splitting all good, all bad dichotomy dialects. Okay. So an individual with borderline personality disorder has to demonstrate at least 5 of the 9 of these. Frantic efforts to avoid abandonment, unstable, intense relationships, identity disturbance, impulsivity in areas like sexuality, spending, reckless driving, recurrent suicidal behavior or parasuicidal behavior, unstable affect, chronic feelings of emptiness, and difficulty controlling anger. Okay, feelings sometimes of paranoia or dissociative symptoms. Okay, so this individual, it's hard to be this person. I said it before, it was hard to be friends with this person. It's hard to be this person. And this person doesn't know why they can't seem to have successful relationships or why they can't do this or can't do that. Now, you'd think it would offend someone to tell them that they have borderline personality disorder. However, when I've had clients come in, or I've heard other people have had clients come in that do and have never known about this disorder, when you tell them about it and you explain it to them and you explain the treatment, there's this sense of relief of like, oh my gosh, that's me. I didn't know this was a thing. Like, and they feel almost like, okay, they're, like I said, relieved that there is something, that there's a name for this. And it's not like just that they're a terrible person. It's that there's this personality disorder going on. And we have therapy. So borderline personality disorder seems to have high irritability. There's abnormalities in the brain, amygdala, of course, because we're thinking about impulsivity, things like that. Emotional dysregulation, issues with distress tolerance, experiential avoidance. Sometimes we see there's childhood neglect or trauma experiences. Sometimes not at all. Often we see marital or psychiatric difficulties. Okay, so this is the big one that we use here, this dialectical behavior therapy. And that is done by Marsha Linehan. In one of your choices of assignments to do, I do have an article on Marsha Linehan. She's amazing. And it finally came out and said, by the way, I used to have borderline personality disorder. And she explains her whole experience of figuring that out and coming to create this therapy that works for people. It's a lot of work, but it works. People also use just sort of mindfulness, mentalization, transference focused therapy. But this is our big one, our DBT. We have DBT workbooks, and now DBT is used for lots of other things too, so don't freak out. If you're going to therapy and you're doing DBT, Marsha Linehan, that doesn't necessarily mean you have borderline personality disorder. It seems to be helpful for a lot of things right now. Zen Buddhism kind of practices are involved in it a little bit. Not necessarily the Buddhism, more the Zen. Okay. Clinicians have to take over this primary role in treatment. They provide this therapeutic structure. They provide support for the client. They involve the client in the therapeutic process. They take an active role in treatment. They deal with the client's suicidal threats and self-harming acts. And they have to be self-aware and ready to consult with colleagues. This is a big one here. Now, interestingly, for most clients, if they cut or want to hurt themselves, we want them to call us so that we can talk them through it and be okay and not harm themselves. With someone with borderline personality disorder, because often these things are to get attention, therapists who do DBT will say, if you cut or hurt yourself in any way, you are not allowed to call me for 24 hours. Some people say 48 hours. But you can call me at any other time. You can call me any time of day, at any time if you just need to practice your skills that we learned in therapy. You can call me if you're struggling, but if you self-harm, you're not allowed to call me for 24 or 48 hours or whatever the person says, okay? I hope you can kind of get that concept, right? And that is if somebody's doing it for attention, but if they do it, they're not allowed to get attention, then they're less likely to self-harm. Okay. I'm going to stop here, and I'm going to pick up on my next recording with histrionic personality disorder. Alrighty.